course, we have a little time for questions. I have, okay, there is a question there, so please, take the microphone, please, here. Yeah. It's on the second row. Is that cube. Yeah.
Okay, thank you. Thank you for the presentations, both of you. Two questions. One is that replissage is not on your strategy for this technique, I realized. If you see the Hill-Sachs lesions, because all these guys have huge or large or medium Hill-Sachs lesions, the first thing. And the second technical part, do you work on the posterior side when you go and use this tensiometer? I mean, you need to clean, debride a little bit before you tension?
Okay, if I can respond, then maybe Marco you can add something. I'm using remplissage in addition to this. If we have a huge Hill-Sachs, it's not my favorite thing. I'm looking for something better than remplissage, but to date, if we have a huge Hill-Sachs, I add a remplissage as well. The second thing, no, we don't clean nothing on the posterior glenoid. It's just, push the buttons against the glenoid, and we have exactly the same results as Pascal Boileau. If you do like this, you will look in your CT scan that the posterior buttons are really close to attached to the posterior part of the glenoid. So, no, we don't need to clean it.
Yes, speaking about the replissage, I used to do it more before the ASA technique. Now I don't do it anymore. I do the ASA technique and that's all. And because I've seen that with the ASA, the humeral head is pushed posteriorly, so the Hill-Sachs is neutralized. And then I have a theory that the engagement, the off track of the Hill-Sachs is a big history. And we have to, I hope that in the future we will be able, like with the software 3D, can see before and not after if the Hill-Sachs is on off track. Right now, what we have only a philosophy. My friend Giovanni Di Giacomo with Itoi, they have shown that there is a philosophy that you have to take care of the Hill-Sachs, either the GBL, okay? But nobody knows right now from a CT scan before can calculate exactly if that Hill-Sachs is on or off track. There are too many variables. The position of the Hill-Sachs, how large the Hill-Sachs is, if it's medial, if it's lateral. And then the laxity of the capsule. This plays an important role. So just to fill that hole could be an option, but before knowing if that lesion of the posterior humeral head is going to be a trouble, you have to calculate before if it's going to be a trouble, and nobody knows right now. So I think that if I do a simple tenodesis of the subscapula in front, I push the head posteriorly, maybe that 2 or 3 millimeter, and I neutralize the Hill-Sachs.
Okay, we have a question, time for a couple of questions more. I have a question for Manos, who talked to us about the Bankart and the association with replissage, the so-called Bankart Plus. So what's your indication from Bankart now? After the first dislocation, do you think there are indications for surgery? In that case, is a Bankart, or what are your indications for Bankart now?
30 years old men with first time dislocation without any serious, with a small Hill-Sachs lesion, Bankart repair.
So, this is a question also of selection of the patient. Historically, we said that after the first dislocation, there was no need for surgery. Now, which patients are eligible for surgery after the first dislocation? Just a patient with this characteristic, or?
The factors that...
I think the cube, maybe.
I don't know. Okay. The the factors that we take into account for having an operation are the bone block, the age, the type of activity, and the if it's an athlete or not, and all of this we consider for operate or not. Okay, for the bunker repairs has been lower rate in our practice. Practically, we don't have many patients that don't have Hill-Sachs lesion. So practically, our practice is to do remplissage. But for a simple case that we take the decision to operate and there is not a serious Hill-Sachs lesion, it's not need to do it.
Okay, thank you. If there is another question, otherwise, okay, yes, there's a question.
Yes, Jean Cagny from Toulouse. I have a question regarding your arthroscopic subscap tenodesis. Of course, congratulations for this very new idea, but I do not understand how you don't have, of course, limitation of external rotation. So you show in your movie clip good elevation, good ER2, but you did not show this one. So my question is, either you have a limitation of external rotation, either you do not have, like your parachutist, very nice results, but probably there is a distension of your tenodesis. So my question is, do you have arthroscopic control after your tenodesis? Do you test your external rotation to see whether you have a rupture or not of your tenodesis? Or do you have any MRI or arthro CT scan to show us a very good healing of your subscap tenodesis with a good external rotation?
Yeah, if I can respond, because that was his idea, and when he showed this technique, my first thing was I will never do this technique because I will have a reduction of external rotation. Then, you know, they approached me and I went to look at their results, and I was looking at the patient that they have no restriction of external rotation. So I said, you have to show us why this, so your question. And they start to study with the MRI study, and I think probably they're ready, Raffaele Russo and Marco, to publish that. You know, after a while, a couple of months, the subscap start to detach from the glenoid, forming scar tissue like a neoligaments. And they have a very nice series of MRI studies that show this. And amazingly enough, these neoligaments work for stability and doesn't restrict the external rotation. So that's my response. I don't know, because, you know, the ideator of the technique is Marco, so maybe he can add something to this.
Okay, at first, at the beginning, you have a visible limitation of external rotation with the arm like that, with the arm at the side, okay, with AR1, because you are going to touch the superior part of the subscap. But when the arms goes into abduction, I'm saying at the beginning of the after 2 or 3 months of the procedure, the limitation of external rotation in abduction is more flexible. Then, after, as Ettore says, the attachment of the subscapularis tendon modifies its way of being in the joint, and there is coming a sort of scar tissue in the upper third of the joint, and it becomes like a fourth ligament that reinforces the coracohumeral ligament, and that's why this kind of scar tissue, or we can call ligament, affords the stability. So you have a sort of good limitation. In conclusion, the quite big limitation you have it in abduction. In abduction, you have quite normal external rotation. Over the time, this scar tissue stretches, and it comes a sort of scar tissue, new ligament in the upper third of the joint. We have done MRI studies, and we are publishing it. So when the paper is going to be ready, you will see in the literature.
Anyway, thank you very much. Oh, we have Tom. So since you are the new moderator and you want to take time to your session, you can ask. Yes, sure.
Yes. I'm sure you're familiar with Roman Brosca. He has a different variety of the technique where he uses a central part of the tendon, and
Yes.
he also has a different fixation point. Have you any biomechanical studies that show that this, because my idea is that you are doing a horizontal restriction to motion of the head, whereas normally the problem is that it's an anterior-inferior dislocation of the head. So I wonder, did you do any biomechanical studies to show in which direction you stabilize
We
the
did,
head when
no,
you do this?
Yeah, we did a biomechanical study just to see the difference between the effect of a simple Banca repair and the effect of Banca repair in anterior and anterior-inferior direction. And I can send you the article. And we saw that the effect of the ASA with the Banca repair is much better than the Banca repair.
In any case, I still do the inferior capsular reconstruction, even if I add the tenodesis of the subscap at the end, because I'm convinced, but I'm still, rely on the capsule in the inferior part if it's possible. Anyway, we have really to finish because we are 5 minutes late. Thank you very much. And Tom, please.